Okay, so this is the second beginning. So a greeting, and as I said initially, salam alaikum to my friends and colleagues in Damascus and other parts of Syria and the world. And so I just like to begin by showing you just some of the elements of my fair city, San Francisco. All of you know about the Golden Gate Bridge, and we're famous for our cable cars, the only moving museum in the country. We have some of the crookedest streets in the country. And of course, sailing on the San Francisco Bay is quite an event. And I would hope and welcome you to visit our fair city if time and God allows. And so let me invite you into my office to the largest medical dental building in the world in Little San Francisco. It's 27 stories tall, and my office is on the 17th floor. So patients enter and go into one of the 8 elevators waiting for them in these marbled walls. And they come to my office, a small office indeed. It's designed for perhaps 4 patients to sit there, or relatives of 1 patient. There's enough seating for 4 people. And the main treatment room, there are only 2 treatment rooms, and I like to keep the room uncluttered because when patients go to the dentist, for many, as we all know, there's sometimes a lurking fear. And for others, they are so frightened, they become phobic about dental care. So by keeping instruments out of their line of sight, it makes it easier for them to sit into the chair without having to try to levitate. And I'm sitting here at my desk and presenting with you. And I should add as a footnote, at the end of my presentation, if there are questions, if we don't have time, you will be able to email me so we can continue the discussion at a later time. The discussion today, or your evening, is about the diagnosis and the treatment of endodontic emergencies. Emergencies come in many shapes and forms. First, what is an emergency? An emergency is not someone who calls up and makes an appointment for a week later. An emergency is a patient who calls and they have to come to our office right now. They are having that much pain or that much swelling. They need immediate attention. Now, they may be a pre-existing patient of ours, or they may be a new patient, but they require urgent care. Now, these emergencies in general fall into 3 categories. There are emergencies for a patient that we may never have seen before, or if we're doing treatment in more than 1 visit, which I discourage, because at another time, perhaps, I have a whole discussion on why all endodontic treatment, whenever possible, should be done in 1 treatment. And I use abundant literature to strengthen and support that statement. And of course, there are emergencies after we complete a case, and the patient may call later that day or the next day or 2, and they're suffering. And so in order to bring some semblance of structure to this presentation, I'm dividing it into 3 parts. So let's talk about the emergencies for possibly a new patient, or a patient that, a prior patient, but we've never seen them for quite some time. So it's the equivalent of a new patient. Let's take a look. Now, when it comes, you see, they call our office, and let me emphasize something here. They're suffering from their experience with toothache, or maybe more than 1 tooth, or maybe they're having pain in the upper or lower jaw, which they assume is coming from a tooth, Well, fair enough. The work that we dentists have to do is to be able to accurately identify exactly what the problem is. Because I'm sure there are a few people in this presentation who have treated a tooth that only later did they discover it never needed treatment. So let's take a look. The first patient who thinks he or she has a toothache might be a patient who's suffering just from sinusitis. Now, sinusitis is not all that complicated to diagnose and differentiate from toothache, real tooth. The next one is temporomandibular dysfunction. Again, they're having pain in a quadrant, and we'll go into that a little further in a while. The third non-dental emergency that thinks it's just a toothache would be the neurologic problem. This is one of the most daunting things that we have to deal with. The neurologic problem that presents as toothache. And finally, all of us, Syria, San Francisco, all over the world, drug abuse, unfortunately, is common. And sometimes there are drug abusers who are looking to get prescriptions for narcotics by pretending they have an endodontic emergency. So let's take a look and actually go into this a little more deeply. As we know with sinusitis, first of all, we know it's bilateral. It'd be very rare for one sinus to become inflamed in full and the other sinus to be perfectly okay. So sinusitis is bilateral. So, well, let me bring it just a little further. As we talk with the patient and gather our dental history and our medical history, we ask the patient, have they had a cold in the last week or two? Or do they have any particular allergies? Does the pain that they're reporting to us increase if they lie down or if they bend over? Can you describe the pain? And the patients will report it's a dull pain. It's not a pain that feels like a knife is cutting into their skin. Rather, it's a dull, fairly strong, it tends to throb. That's the description most commonly of acute maxillary sinusitis. Let's keep in mind, it always involves two or more teeth. And that would be almost always, it involves the second premolar and the first molar. Rarely would it go any further into an anterior or posterior direction. As we do our testing, our clinical testing, we will note that they will have moderate to strong pain with percussion, or if they chew, for example, on a cottonwood stick. If they have any pulps in these teeth, because there could be prior endodontic treatment, perhaps. But if they have any pulps, those pulps should test within normal limits to thermal and electric pulp testing. So as we look at this view of the sinuses, we can see that the sinus, as we know, lies right right on top of the roots of these teeth. Let's take a closer look. If we could look at a section of the sinus and look down on this cadaver specimen, we can see that the roots are protruding into the sinus. So as these sinus cavities fill, the liquid in there, as it sloshes back and forth when they move their head, that will increase the pain. So that's why we have them lie down or bend over. That makes the fluid lying in the sinus cavity move around, and that will confirm our diagnosis. And let's keep in mind, it is almost always bilateral. What do we do for acute maxillary sinusitis. It's actually not all that complicated. Years ago, I learned from our otolaryngologist, ear, nose, and throat specialist, that this is the regimen they use, which I embraced and I have been using whenever I have a patient with acute maxillary sinusitis. So that involves augmentin, the antibiotic, not for very long, just for a few days. And that's 870. Now, this is for a patient that weighs 70 kilogram. If we have a patient that's very small or a patient that's very large, we would have to adjust the medication accordingly. So for the average patient, that'd be 875 milligram twice a day. Neosynephrine nasal spray is very helpful. They recommend Oronate or Claritin, and these antihistamines, perhaps they help. I'm not, there may be some help here. To what degree, I could not say. Now, when I prescribe for pain, because we endodontists, we are the emergency doctors when patients suffer from dental pain. We work with the maxillofacial surgeons. Pardon me. We work with the maxillofacial surgeons. And so the surgeons and the endodontists, that's the front team for managing emergencies that present in the dental environment. So for the average patient, we would prescribe the antibiotic, the nasal spray, Oronate or Claritin, and for that average patient, that'd be 600 milligrams of Motrin and 1 extra strength Tylenol, or 2 extra strength Tylenols. Now, there's a synergy, as I think most of you know, when Motrin and ibuprofen and acetaminophen, when they are taken together, there's a synergy. So the pain relief provided in combination is as strong as providing a narcotic. Now, for countless years, I have been treating patients suffering with extreme pain. And if I have to use a narcotic more than 2 or 3 times a year, I would say that's a lot. That's how rarely I would have to use it, because this combination, I hope this is a good point for you to take back to your office or your clinics from here. The second non-dental emergency that may present as toothache, temporomandibular dysfunction. And what is TMD? Patients may have a history of bruxism, which is not, and especially in this time of the pandemic, bruxism has gone up dramatically here in the USA. And I'm sure other countries might report a similar increase in bruxism or trauma. There may have been an accident and the jaw was under the lower jaw, something in an upward direction caused the jaws to go into rapid opposition, and that could damage the TMJ, the temporomandibular joint. Now, to make sure that this is as it presents, we make sure that the teeth are testing within normal limits. Now, the pain from TMD tends to focus around the pre-auricular area, that is just in front of the ear. And of course, that's exactly where the joint is. So when the patient opens or closes, the pain is for some very strong. We have a clinic here in San Francisco, and this is all they treat, the TMD clinic. And here's what they do, and it's very effective and it's non-invasive. They have the patient, they give them a regimen for the gentle stretching and massage of the TMJ. They have them using warm and cold compresses alternating. They advise them to avoid yawning, to speak softly, no loud singing, certainly no gum chewing, to eat softer foods that do not require a lot of mastication, and of course, analgesics, and for some, even a mouth guard. Then this is one of the most vexing, challenging areas in emergencies that present in our office, ostensibly or seemingly to be a dental problem, when in fact it's a neurologic problem. Let's take a look. Atypical facial neuralgia is a vexing, a very complicated issue. And it's complicated because it mimics real toothache, real pulpal inflammation, real abscess formation. It imitates it perfectly, and yet it doesn't come from the pulps. It does not even come from the teeth. Let's take a look. We know this is not an organic disease, and yet we still don't know why it occurs. But the pain is chronic, meaning it goes on for years. The pain is deep. Here's a key word. The pain is recurring. I'll show you in a moment what I mean. So here's a patient, and I'm going to give you the backstory. The patient will present, and I've seen this in my own office. Over the many years I've been in practice, I've probably seen 12 to 15 cases, similar, 12 to 15 cases of atypical facial neuralgia. And by golly, I did find it very difficult to diagnose, and I'll explain now. So here we have a patient that was treated in New York, and the patient presented to the dentist, and she reported she would touch one tooth and she would say, that tooth is really hurting. I'm having terrible pain. I can't touch it. I can't drink anything hot or cold. So when they describe it, it sounds like toothache. And so we do our testing, and sure enough, it's toothache. And so we do the root canal treatment in one visit, perhaps, hopefully. And the patient calls the next morning to report she feels much better. Maybe a couple of weeks go by, and the patient calls again. This time, she said, the tooth is starting to hurt a lot again. And again, the patient returns, and the tooth cannot be percussed. It's that painful. So the next step is to consider retreatment, or as the dentist did, as you see on the left screen, the dentist decided to simply extract the tooth, place an amalgam in the apex, and replant the tooth. Yes, this actually happened. It's a ridiculous story. And so the patient felt much better after the surgery. Maybe a month went by, and the patient called again. She said, another tooth is starting to hurt just the way the first tooth started to hurt. And so the whole syndrome goes again and again. In other words, it's recurring. And this dentist in New York was not done. Some of the surgery he did without extraction. Others he extracted and replanted. After he almost ran out of teeth to treat, look at all of this. Unbelievable. And when he was all done, the patient had the pain that she originally presented with. Now, is this a service for patients? I don't think anyone would say that's so. So how do we identify these patients? And actually, it's hard for me to say, but I will say from the patients that I've seen along the way, here's my anecdotal experience. This is probably the most typical I could show. And this is a middle-aged female. From almost all of my patients, I had one Black woman and I had one man. All the others were females. So, and they're mesomorphs. In other words, they're not unusually thin and they're not obese. They're middleweight white females. So listen to what the patient reports, because this is one of the keys to recognizing atypical facial neuralgia. As a patient is telling us the history of the pain, she may use a word like, the pain is burning. Well, when patients tell us about pulpal pain, one of the words we do not hear is burning. Pulps do not cause burning pain. Or some might say it's an electric-like pain. Well, pulps again do not cause electric-like pain, nor do they tingle. And so by listening to the words, that should give us a clue that the way the patient presents may not actually be the source of the pain. And so what is done if we finally recognize atypical facial neuralgia? The patient is referred for neurologic consultation. Neurologists often use Neurontin or Tegretol, and that does provide them relief. I don't know the long-term follow-ups on these cases, and there's unfortunately very little in the literature to tell us more about any cohort investigations. Another non-dental emergency that presents ostensibly as a pulpal problem are patients who have postherpetic neuralgia, often called shingles. And of course, we know from prior experience, it's the virus varicella zoster that is a source for this problem. Now, again, we have to listen to what the patient reports, because their first awareness of this, the prodromal sign, is an electric-like pain. I should say the prodromal symptom, an electric-like pain. It's just brief, but that's their first awareness of it. Then the pain becomes deep and it's boring into the skull, and the patient keeps reporting the word burning. And then after that, skin eruptions occur. And these skin eruptions will follow the branches of the trigeminal. So here we see a patient, the ophthalmic branch of the trigeminal, and you can see the outbreak all along following the location of the ophthalmic branch. Now, it's hard to see at this angle, but this patient had a very red eye. The neurologist who took care of him put him on a heavy dose of steroids, which, as a neurologist said, actually saved his eyesight. As for the treatment, we have to recognize that it's not a dental problem, even though they perceive it as the pain in their jaw they thought was coming from the teeth. No, the pain in the jaw, in this case, the upper jaw, but the outbreak was on the ophthalmic branch. I would have expected the maxillary branch, but they're referred to a neurologist, and the neurologist will use steroids, and his eyesight, fortunately, was saved by timely application of steroids. And then there's still another neurologic problem, tic douloureux, or trigeminal neuralgia. Now, I think most everyone knows trigeminal neuralgia, and what's characteristic is that there's a place on the face, almost always it's on the face, usually no higher than the eye, and it may go all the way down to the base of the mandible. The pain is there's a trigger spot. There's like one spot, if you touch that spot, it will cause a severe, a sharp, electric-like pain. Now, here's the thing that helps us diagnose this. Right after they recover and that pain lasts only a few seconds, then you can go back and touch the same spot and they feel nothing. It's as if they were anesthetized. So there's that trigger zone, and that's how this is diagnosed, looking for the trigger zone. It's almost always unilateral, usually on the right side for middle-aged and older females. The treatment, again, we refer to neurologists, and there are all kinds of things that they could do, usually Neurontin, Dilantin, Tegretol, the usual drugs that they may prescribe. And of course, the drug abuser who knows exactly what to say to make it sound like it's a pulpal emergency. Well, if we listen well, we will not give them any narcotics. And as I said earlier, I rarely have to prescribe narcotics in my practice. And the drug abusers, they tell us exactly what they need to relieve the pain. So they would say, I'd like to have Percodan enough for about a week to keep the pain down. Well, if they know the drugs and the dosage and how long it should be taken, that's exactly the reason not to prescribe it. Now, as for endodontic emergencies, then we have the dental side of this, where there actually is a dental problem and it is an emergency. So it very well may be irreversible pulpitis. It could be an abscess. And if it's an abscess, it could be an endoabscess and possibly a perioabscess. Let's take a look. If we have a patient who presents and we can confirm with our history gathering and our testing that we have indeed irreversible pulpitis, the first thing we want to do is anesthetize a patient, remove the pulp, clean and shape as much as possible. I'll expand upon that in a few moments. And then again, the Motrin Tylenol combination. The periodontal abscess, of course, is always a pocket, always. Now, with the periodontal abscess, as we take out our periodontal probe, if there's a periodontal abscess, the pus will actually flow out of where the probe had just explored. Of course, it will be, it's usually moderate pain to palpation. And radiographically, we may or may not see any demineralization around the tooth. It doesn't always cause, at least in our conventional imaging. Now, if we took a cone beam, it's very likely we would be able to identify some demineralization. And in the more perfect world, it's a periodontal abscess, but the pulp is vital. I'm not going to go into when the pulp is non-vital and it's a perioabscess. That's beyond what this presentation is about. If we have a periodontal abscess, the first thing we want to do is to anesthetize a patient so they stop suffering. And of course, we have to use a vasoconstrictor. Again, the periodontal probe will establish drainage. In that area where there was drainage, we allow it to drain with good aspiration. When the draining stops, and we irrigate that area gently with chlorhexidine, and then prescribe analgesics. And depending on the case, we may or may not prescribe an antibiotic. Now, the most common emergency we will see in practice is irreversible pulpitis. The patient may say, I woke up in the middle of the night, I had this terrible pain, I was doubled over with pain, and they almost crawl into the office. And actually, one time, some years ago, I had a patient, he was a psychologist. When he came to our front door, because I had to see him on a Saturday morning, when he came to our front door, he was literally on his knees crying, waiting for me to arrive. So that's what I mean when I say the pain can be exquisite. So the pain will be quite strong. That's why they are an emergency. There will be lingering pain. Usually it's with cold. In the more advanced cases, there will also be pain with heat as well. There will be often spontaneous pain will radiate along any of the branches of the trigeminal. So here we have a case diagrammatically to show the three branches. And so let's say the patient has the upper left first molar as the source of the pain. So when the pain is radiating, we don't even know, is it an upper tooth? Is it a lower tooth? Is it a molar? Is it a premolar? And which molar or which premolar? So how do we find out? Actually, it's not all that complicated. Let me show you how. There will, of course, be pain with percussion and possibly chewing. And so by percussing and having them chew on a cottonwood stick, we can confirm which tooth is the source. So we want to confirm the diagnosis with intraligamentary anesthesia. In other words, so we have an intraligamentary gun, and I hope everyone listening to this webinar has an intraligamentary gun. If you don't, before the day is over, or for the next day, for those of you in Syria, tomorrow, get yourself an intraligamentary gun. It's really important. And so it uses an ultra short 30 gauge needle. And the needle, of course, can be bent in any direction. And here's the thing and how it's used. So the patient is sitting in the chair and they're suffering with pain. If we put that needle into the distal sulcus and express 0.2 cc of that local anesthetic, which includes a vasoconstrictor, the pain will be gone in less than 10 seconds. And I mean completely gone, not for very long, for just a few minutes perhaps, but that's all we need to confirm the source of the pain. So if I were to leave you with just one point today, I would say this is the point, your takeaway point to embrace and bring into your office. And how do we treat the endodontic abscess? Well, as I think many of you are already doing, we'll anesthetize a patient, of course. We will establish drainage. We'll talk about that in a moment. We'll do as much cleaning and shaping as possible, and I'll qualify that. We want to make sure the tooth will be in hypoocclusion, and of course, analgesics and antibiotics when necessary. Now, this is an example of a patient who presents. He's one of our football players, he was one of our football players. You can see his face is as wide as it is tall, a very big man. So here he is suffering with severe pain. And actually, although it looks like it might be a premolar, the pain was actually occurring from his upper right cuspid. The source was right here, but it was expanding out in this direction. So how do we anesthetize a patient like this? Very complicated, and maybe not so complicated. Let's take a look. Something to consider, of course, in these matters, we always want to use a longer lasting anesthetic like Marcaine with a vasoconstrictor. But we know the infraorbital is right here. We can feel that when we palpate on a patient or even on ourselves. If you palpate the infraorbital ridge, you can find exactly where this aperture is. And of course, we have the trigeminal coming right out here. So we cannot inject right into this because we all know if you inject into an abscess, nothing happens. The acids of the abscess will neutralize the anesthetic immediately. But there's another choice, and that is right here. Consider if we could just freeze this one spot and extra orally administer just half a cc of a local anesthetic. That will provide a reasonable amount of anesthesia until we can get some drainage. Now, I use this only to bring out the point. This, of course, is not anything severe, but for teaching purposes, I like to use this case. So we want to establish drainage. Now, I'm sure from the people that are listening to this webinar, some of you have already had the experience. You feel with your small finger, your pinky, and you palpate the area. It feels soft, we think. It feels fluctuant, we think. And you've had the experience, you make an incision, and all you get is bleeding. That does not help. So how do we make sure that if we do an incision, that we actually get purulent drainage? So we're about to make an incision, but before doing that, here's what I would suggest. Using a 27 gauge needle, go right into the center of the abscess and aspirate, express 1 or 2 drops and then aspirate. If there's going to be real drainage, you'll see that in the carpule. Of course, if it's a real abscess, one small vertical incision will allow drainage to continue. Now, once we do get drainage, we want to make sure we get enough drainage, just because it's possible for some of the drainage to occur, and then the incision site may epithelialize and the swelling can recur. So what I recommend is after the drainage stops, use the small finger and gently press in this area and gently press in this area, pushing towards the vertical incision. So if there's any purulent exudate, it will drain out through that incision. So we want to complete the incision and drainage, the I&D. Now, a long time ago, they used to recommend suturing some rubber dam in here. Not a good idea. Rather, to just use small fingers, make sure all the drainage is done, and just leave it alone, because nature it does not require a suture. Nature will allow it to epithelialize within 24 hours. It's very rapid. So the tooth is open to drain, of course. And then there's the old adage, we were taught years ago, leave the tooth open to drain. That's the last thing to think about. And I urge, do not leave a tooth open to drain. Rather, if the tooth needs to drain for 5 minutes, perhaps even 10 minutes, which is rare, usually in just a few minutes, drainage will stop. After the drainage stops, copious irrigation, at least as much cleaning and shaping as is reasonably possible, and then to put something, and I'll show it in a few moments, a calcium hydroxide dressing in there with iodoform, and that will allow the patient to return back home, and the suffering is over. I like to use Vite Apex because it has a nice needle-like tip, which can go about to the middle third of the canal, and we gently express the calcium hydroxide with iodoform, which is excellent because it will neutralize any acids remaining in there, and because it has a silicone base, it does not set. So when the patient returns, all the calcium hydroxide can be easily removed. And that's what I like about Vite Apex. It does not set. It can be removed easily with number 20 or 25 file. Copious irrigation. One cannot irrigate too much. Irrigation is critical. So in this year, the most common and the most recommended intracanal medication is calcium hydroxide and iodoform, like Vitapex. Now, after we do that, we want to place a cotton pellet in the pulp chamber that has been saturated with chlorhexidine. And we cover that with some temporary filling material. So for the abscess, let's just review. We want to anesthetize, establish drainage as best we can, cleaning shape as much as we can, make sure the tooth is in hypoocclusion, and the analgesics and antibiotics, as I discussed earlier. The analgesic regimen for the average patient, 70 kilogram, Motrin, ibuprofen, 600 milligram. And for the larger patients, may want to use 800 milligram, and sometimes even more, depending on the really large patients, along with Tylenol. Tylenol is excellent. 2 Tylenols every 6 hours, along with Motrin, 600 milligram. The combination is remarkably effective. Now, if there are some patients that, for whatever the reason, you have some concern about, will the analgesic regimen be sufficient? So prescribing a few Vicodin as an insurance, not for them to take, but in case they might need something, they would have it. Something stronger, that is. Now, just to give you one of many references, this is from a systematic and meta-analysis that was published in the Journal of Endodontics almost 3 years ago. This is an excellent paper if you want to read about why I've recommended what I have. As for the antibiotic I prefer to use is clindamycin because the literature reports it penetrates bone better than most other antibiotics. Now we have the abscess in case the treatment is in 2 or more visits, the abscess that may occur after the first treatment, but before the case has been obturated. And the flare-ups occur because, of course, there are microbes and endotoxins still inside. There may still be some debris. If instruments are extended beyond the apical foramen, that increases the risk of post-treatment flare-ups. Or if the tooth occlusion is not adjusted, and I think most of you already know, when you treat a patient endodontically, it's a good idea to make sure that the tooth is in hypoocclusion. Now, let's think about that for a moment. If it's a posterior tooth, it will need coronal coverage, and that could be an onlay, that's fine, or a crown, that's fine. But the coronal surface, the occlusal surface, will have to be covered. Now, if a patient comes back and they report, I'm still having a toothache there, of course, we want to run through the whole series of tests that I mentioned earlier, and we want to test adjacent teeth and sometimes even opposing teeth. Because if a patient has a mouth that has been neglected, anything is possible. So how do we assess these flare-ups? Because we initiated treatment, but the case has not been completed yet. We have to gauge how strong is a pain. We have to have an index of suspicion that there could possibly be another tooth, often by listening to the patient. Because if we start treatment and we've done our pulp extirpation at some degree of cleaning and shaping, the patient returns 3 days later, and they say, I'm still having a lot of pain with something ice cold. Well, right there we know there's another tooth involved. And the treatment for these abscesses is just what I said before. We want to establish drainage, check the occlusion, make sure that we've handled it with our analgesics and antibiotics. And then we even have the cases of we've obturated the case, the patient is ready to have the final restoration, but the patient reports he or she is still having pain. Well, we want, of course, to double check and to find out why they're still having pain. Could it be the occlusion? And often that's all it requires is occlusal adjustment. We may need to prescribe antibiotics and analgesics. We may even have to do apical surgery. From my experience, one of the most common causes for post-obturation flare-ups is the untreated root canal. In our school, the University of the Pacific, when we teach endodontics, we teach that all molars have at least 4 canals unless the dentist can prove there are only 3. So we start out assuming the mesial buccal will have 2 canals. So post-treatment flare-up prevention, we want to make sure that cleaning and shaping has been thoroughly and look for that supposed extra canal. We want to make sure we don't overextend our instruments beyond the apical foramen and that the tooth is in hypoocclusion. Routinely, it's a good idea to keep patients on the nonsteroidal regimen that I mentioned earlier for usually 3 days. That should be quite enough. Patients also need to understand that nature is not magical, so they should have some transient, temporary, mild discomfort for a few days, and then it should be gone. And as for prophylactic antibiotics, I would urge, do not do that. Now, if the patient has some systemic disease where their system is somewhat impaired, then it may be prudent to more routinely prescribe an antibiotic. But absent any systemic reason, let's try to avoid overprescribing antibiotics. Now, I'm sure for the many people that are in this webinar, some of you out there have had this experience, and I'm going to tell the rest of you what the experience was like. The hypochlorite accident. And every year I see about, I'm going to estimate between 3 and 5 of these every year. That is, other dentists who've been doing root canal treatment, and somehow they end up in my practice. Well, the first thing, there's no problem in knowing what the problem is. There will be, the patients will scream. Yes, they will actually scream. There will be immediate swelling. As we are looking at the patient, you can literally see the cheek expanding. I'll show you in a few moments. There'll be profuse bleeding through the root canal. It looks like the aorta has been severed and the blood is pumping out of the canal. It's a scary thing to see. The pain is exquisite. It is severe on a scale from 1 to 10. The pain is a 10. So here we have a photograph of a young girl where this happened about a minute earlier. And it's actually her left cheek that it just began. The range of the swelling is not showing yet. So how did we get this photograph? Well, this happened at the University of the Pacific Dental School, and one of our 3rd-year students was doing root canal treatment in one cubicle. In the next cubicle, they were treating a crown and bridge case. There was a photographer there who had a tripod. He was photographing the case. This photographer served during World War II as a combat photographer. So when he heard this scream, he didn't pause for a moment while he was photographing the crown and bridge case. He simply turned his tripod and he began photographing every 5 seconds. this was a best documented case. To this day, no case has been documented as well as this case. And this is the first case in dental literature. And so the student who did this became petrified. The patient was screaming. The entire clinic could hear this young lady screaming. It was terrible for her. It was also terrible for the student. So what do we do in cases like this? So it's easy for me to sit here and tell you sitting there, stay calm. But I can assure you, if something like this happens, you will get a rush of adrenaline that you're ready to levitate. It's very scary to witness. I hope you never witness it, but if it should occur, you'll have no trouble making the diagnosis. So we want to reduce the pain if possible. As a practical matter, often it's not possible. It requires IV sedation. We have to allow the bleeding to continue, and the bleeding is profuse. And of course, we'll prescribe antibiotics and analgesics. We refer the patient to our maxillofacial surgeons, fortunately, right there in the clinic. And we want to make sure the records are filled out thoroughly, because at a later time, questions may arise. We want to follow these patients closely. So let's take a look. Here is this young lady the following day. That is quite a black eye that she has. The student took care of her. The day it happened, he drove her home. He called her the next morning, had her come into the school. At the end of the day, he followed. Every day he called her at least twice a day. And so here's what was done. We had to give her IV sedation. We trephinated around the area. Antibiotics and steroids and analgesics were all prescribed. So here she is when it happened. Here she is the next day, and 10 days later, she was whole again. Now, this was a terrible story, and it turned into a wonderful story, because this was so frightening for the student that this student wanted to quit the dental school and go into accounting. But we gave the student some psychological counseling. He stayed on. He completed the dental program. He went on to become a very prominent dentist in the capital of California, Sacramento. And he was so grateful for what he learned that many years later, he made a donation to the school of $1 million. So that's what I mean by a terrible story becoming a wonderful story. So I hope I was able to bring up at least one or two points here that you have as a takeaway. So when you return to your office, there's something you can do that you may not have been able to do or thought about to do earlier. Now, please feel free to stay in contact with me. If you have any questions, I'm not sure if the time allows now, but if you have questions, you can always email me. That's my email. And when my time allows, I'll respond to your question. But for now, I'll say to all of you, Salam Aleichem. So, yes, here we are. Can you hear me?
Okay, yes.
Yes.
Thank you, Professor Cohen, for this lecture. Yeah.
You're quite welcome. And take good care.
Okay, Professor Cohen, thank you very much for your informative lecture. That was great, all the details and the diagrams. Yeah. We have some, maybe 2 or 3 questions. Please, if you don't mind.
Okay.
Okay. In the case of sinusitis, inflamed sinus, do you advise to refer it to NTA doctor?
I'm sorry, I didn't quite. Do I what?
In the case of inflamed sinus, do you advise to refer it to ear, nose doctors?
Yes. When I first went into practice, that is what I did. But as I began to see that all these cases were being treated the same way, and it was a non-invasive approach, I just embraced what they were doing, and so it made it easier for the patient. And so and we have an allergy season here in San Francisco. So yes, I do treat these cases. If I cannot get it to improve within 3 or 4 days, then I would refer them to an otolaryngologist.
Yeah, also in the slides, I think there is a case of Ramsey-Hunt syndrome. Yeah.
I'm not sure what syndrome.
About herpes disease. I think it's Ramsey-Hunt syndrome. Yeah.
Okay. Yes.
Also, do you refer to ophthalmologists?
Yes.
Or not?
Ophthalmologist or neurologist, depending on the nature of how it presents. And I don't recall if that went to an ophthalmologist or a neurologist, but they're both able to take care of these cases.
Sometimes, do you feel that the whole, I mean, marsupialization to make a tract, like a tract in necrotic cases, it's advisable or not?
Marsupialization actually does work. It's on a case-by-case basis, but it's a reasonable consideration. I happen to like marsupialization as well.
Also, sometimes, do you advise for using corticosteroids inside the canal as a paste?
No,
in the canal. Yeah.
I understand that as an intracanal medication to use steroids. I do not recommend that because it's easy to put a mask on what is really going on in there. So in case there should be a flare-up, it could become much more severe because it was camouflaged and disguised with corticosteroids.
Even in vital cases?
In vital cases, perhaps. There is some literature on that. Unfortunately, it's not literature with cohorts, but rather more like case reports. So yes, there are case reports in the literature where steroids have been used effectively. Additionally, as long as we're speaking about steroids, I should also mention for patients when treatment has been completed, I know there's a large group of dentists that like to inject a steroid right into the site, right into the mucobuccal fold. They'll inject about 1 cc of a steroid to reduce the post-treatment pain.
I think in your previous edition, in your book, you recommended it. Yeah, is it right?
That's right. Okay. Yes, quite right.
Thank you very much. Thank you, Professor Cohen, for your time, and we hope to see you again in this webinar.
It's been a pleasure. Take care, and God bless you all.
Thank you very much. Thank you.
You're welcome.
Bye-bye.
Bye-bye.